Hello everyone and welcome to today's exciting class. Today we are going to tackle one of the biggest challenges in head and neck oncology. We are going to discuss the management of locally advanced laryngeal and hypopharyngeal cancers. Look at the title on the screen. Our focus today is entirely on organ preservation strategies. As an oncologist, I see patients with locally advanced laryngeal and hypopharyngeal cancers in the clinic every single day. They are terrified. They are not just terrified of cancer. They are terrified of losing their natural voice. They are terrified of losing their ability to swallow normally. They are terrified of how their physical appearance will be after the surgery. Historically, we had only one brutal treatment for them. Our goal used to be cure them of cancer with any functional cost. In those days, we used to do upfront total laryngectomy for every single patient who developed locally advanced laryngeal or hypopharyngeal cancer. But as you will learn today, that approach has shifted completely over the last 2 decades. Look at the 3 pillars on your screen. This is our modern goal. First, our treatments are now driven by strict evidence and innovation. We do not guess, but we rely on landmark clinical trials. Second, we are dedicated to advancing outcomes and preserving life. We must cure the patient because survival always comes first. But third, and most importantly, we now aim to preserve function and protect voice. We want to cure the cancer while keeping their larynx completely intact. Over the next 2 hours, we will study the critical T-staging, clinical approach to diagnosis, the landmark trials, and the exact multidisciplinary approach we use to decide between surgery and chemoradiation. Let us begin. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi for over 12 years. I have been practicing and teaching oncology for more than a decade. I did my MBBS and post-graduation from CMC Vellore. Then I did my DNB at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. I pursued a fellowship at the Royal Marsden Hospital in London and have later undergone specialized training from the United States. I have published almost 85 research articles and abstracts in PubMed indexed international journals. Before we dive into advanced cancer today, I want to share something very useful. Look at the pictures here. I have created a series of 6 foundational videos specifically for you. In these videos, you will learn how to take a proper history and perform a complete physical examination. You will also see how to approach these patients in the outpatient department and do an OPD-based endoscopic staging. Next, you will learn exactly how to assess laryngeal functions in a practical way. You will also learn how to correctly read and understand their imaging scans. Then you will learn a general treatment outline for laryngeal cancers. Finally, I have a detailed discussion on how to choose between transoral laser microsurgery and radiotherapy for early glottic cancers. I have provided the links for you to watch them in the video description below this video. Please do watch them. Those videos will form a very strong foundation for your understanding of this topic. Let us now move to the next slide and start today's topic. How should you proceed step by step when you get a patient with laryngeal or hypopharyngeal cancer? Imagine you have taken detailed history and physical examination. What next? This slide shows the strict sequence of 11 steps for evaluating laryngeal and hypopharyngeal cancers. I have already uploaded 2 videos on this. Please watch them. You must deeply understand that this is never just a random checklist. It is a highly structured pathway carefully designed to prevent dangerous errors. We can divide the entire diagnostic journey into 4 distinct phases, each phase having its own steps. Let us begin with phase 1, which is your initial visualization of tumor while the patient is still in OPD. Step 1 is your traditional indirect laryngoscopy. Step 2 is your modern rigid and Hopkins endoscopy. During this step, you must strongly consider combining your examination with video stroboscopy and narrowband imaging. Phase 2. Phase 2 focuses entirely on staging and tissue diagnosis. This phase is where you establish your complete T and an M stage. Step 3 is ordering your local cross-sectional imaging. You will typically use a high-resolution CT scan as your workhorse and as your default initial imaging modality. You may sometimes order an MRI, not routinely, but as a problem-solving tool. Remember a golden rule. Imaging must always happen before you take any biopsy. I have taken a detailed lecture on imaging. Please watch it. Step 4 is to do a direct laryngoscopy and biopsy. This is your ultimate anatomical mapping exercise to establish the definitive histopathological diagnosis. This is your last and the best time to completely and accurately map mucosal disease. If your patient has early glottic cancer and if you have not done video stroboscopy and narrowband imaging earlier, you should do it now during your direct laryngoscopy. Step 5 is the mandatory pan endoscopy. You must perform a triple endoscopy to rule out any hidden synchronous second primary tumors. Step 6 is your comprehensive metastatic workup. You must diligently establish the M stage early in your evaluation. The most frequent site for distant metastasis is the lung. You will typically order a contrast-enhanced chest CT or a PET CT for advanced disease. Then we enter phase 3. In this phase, we established a vital, functional and supportive baseline. These patients often have severely compromised airways and severe swallowing difficulties. Step 7 is your laryngeal functional assessment, utilizing tools like FEES, VFSS or video fluoroscopy. Step 8 is to assess nutritional status of the patient. You must actively consider early feeding tube placement to fight cancer cachexia. Step 9 is a thorough dental assessment and prophylaxis. This is a critical safety measure before starting any radiotherapy. Step 10 is a formal speech and swallowing assessment. This establishes a baseline to guide their long-term post-treatment rehabilitation. Finally, we arrive at phase 4, which is done to see if the patient is ready and fit for cancer-directed therapy. Step 11 is your rigorous pre-treatment fitness workup. You must run complete blood panels. You may have to do a pulmonary and cardiac assessment for these patients. You must definitely confirm their cardiopulmonary reserve is strong enough to safely tolerate aggressive therapies. Only after completing every single one of these 11 steps are you truly ready to initiate definitive treatment. Also, do not change the sequence of evaluation tools. You must follow these 11 steps in sequence as shown in this slide. Now that we have taken history, done physical examination, indirect laryngoscopy, direct laryngoscopy, taken biopsy from the primary, done local cross-sectional imaging and metastatic workup, it's time now to stage the disease. We will use AJCC 8th edition staging system for this purpose. As residents, you must know this staging by heart. It is the most important factor in deciding the exact treatment for your patient. It tells us if we can safely save the voice box or if we need to remove it completely. To make it easy to understand, we will divide the staging based on the exact location of the tumor. First, we divide the larynx into 3 separate parts. These are the supraglottis, glottis and the subglottis. After that, we will also look at the staging for the hypopharynx. I have created very simple diagrams to help you remember these rules easily. Since nodal staging is similar for all sides, I will not be doing it in this lecture. Let us look at the next slide and start with supraglottic cancer first. Let us start with the T staging for supraglottic cancer. Look at the diagrams on the screen. First, we have the T1 stage. I want you to remember this as the 1 and mobile stage. As you can see in the first picture, the tumor is limited to exactly one single subsite of the supraglottis. At this stage, the vocal cord mobility is completely normal. Now move your eyes to the second diagram, which shows the T2 stage. You can remember this stage as more than one but still mobile. Here, the tumor has grown and involves more than one subsite, or it can even spread to nearby mucosal regions just outside the supraglottis. These outside regions include the base of the tongue, the vallecula, or the medial wall of the piriform sinus. But the most critical point to remember here is the mobility. Even though the tumor is spreading the larynx is not fixed. The vocal cords are still perfectly mobile. This mobility is the key factor that keeps the tumor in the early stages. Now let us move on to the T3 stage for supraglottic cancer. This stage is a critical turning point in laryngeal cancer. The first major feature you must remember is vocal cord fixation. If the tumor causes the vocal cord to become fixed and immobile, it automatically becomes a T3 stage. But what if the vocal cord is still mobile? It can still be a T3 stage if the tumor invades the deep internal spaces of the larynx. These deep structures include the postcricoid area, pre-epiglottic space and the paraglottic space. It also includes the inner cortex of the thyroid cartilage. Please pay close attention to the word inner cortex. As long as the tumor stays on the inside of the thyroid cartilage, it remains a T3 stage. We will soon see what happens when the tumor breaks outside this boundary. What is T4 stage for supraglottic cancer? There is a T4A and T4B stage. The T4A stage is known as the moderately advanced local disease. You can think of this as the breaking out stage. Here, the tumor breaks completely outside the structural boundary of the larynx. It invades right through the outer cortex of the thyroid cartilage. It can also spread to soft tissues completely outside the larynx. These outside tissues include the trachea, the thyroid gland, the esophagus, and the strap muscles of the neck. Now let us look at the T4B stage. This is the very advanced local disease. You must remember this as the danger zone stage. At this point, the tumor has invaded extreme and critical structures. It may invade the prevertebral space at the back of the throat. It may go down into the mediastinal structures in the chest, or it may completely surround and encase the carotid artery. If a tumor reaches this T4B stage, it is considered inoperable. Now let us move to T staging for glottic cancer, vocal cord cancer. First, we will look at the T1 stage. In glottic cancer, T1 stage is divided into two parts. First, T1A. Here, the tumor is limited to just one single vocal cord. The mobility of that vocal cord is completely normal. Next is T1B. Here, the tumor has grown to involve both the vocal cords. But again, the most important point is that the mobility of both cords remain perfectly normal. Next, T2 stage. At this stage, the tumor starts to spread beyond the vocal cords. It can extend upward into the supraglottis, or it can extend downward into the subglottis. But look carefully at the blue box at the bottom. This is the crux of the matter for glottic cancer. At the T2 stage, the vocal cord can develop impaired mobility. The movement becomes sluggish, but the cord is not completely fixed yet. Next is T3 stage for glottic cancer. The most important feature of the T3 stage is vocal cord fixation. If the tumor causes the vocal cord to stop moving completely, it becomes a T3 cancer. This is a very important clinical turning point for deciding our treatment. But we must also look at where the tumor is growing deeply. The cancer is also classified as a T3 stage if it invades the paraglottic space. It is also a T3 stage if it invades the inner cortex of the thyroid cartilage. Just like we saw in the supraglottic cancer earlier, the word inner is very important here. As long as the cancer stays on the inside of the cartilage boundary, it remains a T3 stage. Now we will discuss the final stages of the glottic cancer, which are T4A and T4B. The T4A stage is known as moderately advanced local disease. Again, like supraglottic cancer, you can think of this as the breaking out stage. Here, the cancer breaches the structural boundary of the larynx completely. It invades right through the outer cortex of the thyroid cartilage. Outer cortex. It can also spread into tissues entirely beyond the larynx. These outside tissues include the trachea, the thyroid gland, the esophagus, and the soft tissues of the neck, such as strap muscles. Next is T4B stage, which is very advanced local disease. We call this the danger zone. Danger zone stage because the tumor invades extreme structures. The cancer may invade the prevertebral space at the back of your throat. It may extend downward into the mediastinal structures in the chest, or it may completely surround and encase the carotid artery. If a tumor reaches this T4 B stage, it is considered very difficult to treat. These are unresectable tumors. Now let us look at the T staging for subglottic cancer. First we have the T1 stage. Here the tumor is strictly limited to the subglottis. Next is the T2 stage. At this point the tumor extends upward to involve the vocal cords. The vocal cords may still have completely normal mobility or their movement may become impaired. Then we have the T3 stage. Just like in the other regions of the larynx, vocal cord fixation is a key feature here. If the tumor causes the vocal cord to become completely fixed, it is a T3 cancer. It is also classified as T3 if the tumor invades the inner cortex of thyroid cartilage. Remember, as long as it does not break outside the inner cartilage boundary, it stays in the T3 stage. Now we will discuss the advanced stages of the subglottic cancer, which are T4A and T4B. The T4A stage is known as moderately advanced local disease. Again, we can call this the breaking out stage. At this point, the tumor breaks completely outside the structural boundary of the larynx. It invades right through the cartilage of the thyroid cartilage. It can also spread into tissues entirely outside the larynx. These outside tissues include the trachea, the soft tissues of the neck, and the strap muscles. It can also invade the thyroid gland, the esophagus, and the deep muscles of the tongue. Next, we have this T4B stage. This is the very advanced local disease stage. We call this the danger zone. Here the tumor invades critical and extreme structures. It may go backward into the prevertebral space, it may go downward into the mediastinal structures in the chest, or it may completely surround and encase the carotid artery. If the disease reaches this stage, it becomes very difficult to manage. These are unresectable cancers. Let us move to the hypopharynx. We will start with the early stages of the hypopharyngeal cancer, which are T1 and T2. First, we have the T1 stage. In this stage, the tumor is small and measures 2 centimeters or less in its greatest dimension. It must also be strictly limited to just one single subsite of the hypopharynx. Next, we have the T2 stage. Here the tumor grows larger, measuring more than 2 centimeters but up to 4 centimeters. Alternatively, it can be classified as T2 if it invades more than one subsite or an adjacent site. But there is one absolutely critical clinical rule for both these early stages. The crux of the matter is the mobility of the vocal cords. For a tumor to remain in the T1 or T2 stage, there must be no fixation of the hemilarynx. The mechanical movement of the larynx must remain completely normal. If the tumor causes the hemilarynx to become fixed, the staging automatically increases to a higher level. T3 stage. T3 stage hypopharyngeal cancer. This stage is considered moderately advanced local disease. There are 3 main conditions that put a tumor in this T3 category. First, we measure the maximum size of the tumor. If the tumor is more than 4 centimeters in its greatest dimension, it becomes a T3 cancer. Second, we must check the mechanical movement of the larynx. If the tumor causes fixation of the hemilarynx, it is automatically a T3 stage. This means one half of the voice box has completely stopped moving. Third, we check if the tumor is spreading downward. If the cancer extends into the mucosa of the esophagus, it is also classified as T3. This downward spread happens often because the hypopharynx is directly connected to the esophagus. Now let us examine the advanced T4A and T4B stages for hypopharyngeal cancers. The T4A stage represents moderately advanced local disease. At this stage, the tumor invades adjacent cartilaginous and soft tissue structures. This includes direct invasion into the thyroid cartilage, the cricoid cartilage, or the hyoid bone. It can also extend beyond the pharyngeal wall into the thyroid gland, esophageal muscle, or the central compartment soft tissues. Next is the T4B stage, which is very advanced local disease. This stage is defined by the tumor invading extreme anatomical boundaries. It is classified as T4B if there is a deep invasion into the prevertebral fascia. It also includes tumors that encase the carotid artery or extend downwards into the mediastinal structures. Tumors reaching the T4B stage are generally considered unresectable. With this, we have now completed the individual T staging for all three sites of larynx and hypopharynx. To make it easy to remember, we can identify some universal patterns for advanced stages. Let us first group the three subsites of the larynx, which are the supraglottis, glottis, and subglottis. For all these laryngeal subsites, the first universal pattern we notice is that the T3 stage is defined by two major features. These features are the fixation of the vocal cord and the invasion of the inner cortex of the cartilage. Next, the T4A stage for the larynx always involves a complete anatomical breach. The universal pattern we notice here is that the tumor invades right through the outer cortex of the cartilage or spreads into the extralaryngeal soft tissues. Finally, we have the T4B stage, which is a universal rule for both the larynx and the hypopharynx. No matter where the tumor starts, it becomes a T4B stage if it invades prevertebral space, encases the carotid artery, or reaches the mediastinal structures. Remember, these simple patterns will help you stage any advanced tumor quickly in the outpatient department. These are the three high-yield clinical points with regard to staging of these cancers. First is the fixation rule. In the supraglottis, glottis, and subglottis, vocal cord fixation is a major turning point. If the vocal cord is completely fixed, the disease immediately escalates to the T3 stage. Second is the cortex divide. You must carefully check the thyroid cartilage on your imaging scans. If the tumor invades only the inner cortex, it remains a T3 stage. But the moment the tumor breaches the outer cortex, the staging jumps to T4A. Third is the T4B, absolute rule. It does not matter which subside the tumor originated from. If you see prevertebral space invasion, carotid artery encasement, or mediastinal spread, it universally dictates a T4B stage. Now see the overall stage grouping. This table shows how we combine the primary tumor stage with the nodal stage. This combination gives us the final disease stage for our patients. Stage 1 and stage 2 consist of T1 or T2 tumors with absolutely no regional lymph node spread. Once a patient develops a T3 tumor or a single positive node, they enter stage 3. Next, we have the stage 4A. This stage includes T4A tumors that break through the outer cortex of the cartilage. It also includes any patient with N2 nodal disease. N2 disease means multiple nodes or bilateral nodes are involved. Then we move to the highly critical stage 4B. This includes the extreme T4B tumors that invades the prevertebral space or surround the carotid artery. It also includes N3 nodal disease. N3 disease means a very large node or any node with tumor spread outside its capsule. Finally, stage 4C represents patients with distant metastasis, most commonly to the lungs. Let us precisely define what makes up locally advanced disease in laryngeal and hypopharyngeal cancers. A tumor is classified as locally advanced if the primary lesion is either T3 or T4 category. It is also considered locally advanced if there is any clinical evidence of positive regional lymph nodes. In our staging framework, this corresponds directly to stage 3, stage 4A and stage 4B disease. This definition is absolutely critical because it decides our entire treatment approach. For early stage disease such as T1 and T2 with no nodal spread, we typically use single modality treatments such as definitive radiotherapy or transoral laser microsurgery. However, for locally advanced disease, we face a highly complex clinical dilemma. We must carefully decide whether to perform a radical surgical resection, which usually means an upfront total laryngectomy, or to attempt a non-surgical organ preservation strategy. The organ preservation protocols require intensive multimodality therapy, typically involving radical concurrent chemoradiation or induction chemotherapy followed by radical concurrent chemoradiation. Our entire discussion from this slide onward will focus exclusively on managing this specific and challenging group of patients. Let us now move on to the principles of local imaging for laryngeal and hypopharyngeal cancers. Accurate cross-sectional imaging is a very important step in our diagnostic workup. It helps us precisely evaluate the deep tissue extent of the tumor. It also helps us check for cartilage invasion and determine the regional lymph node status. These radiological details are absolutely critical for accurate staging and planning the definitive treatment. Because imaging is such a vast and important topic, I have created a separate detailed video lecture focusing entirely on this subject. You can find the link in the video description to watch this video. I strongly encourage you to watch it to understand the radiological evaluation completely. For today's session, we will focus only on the essential imaging workflows and practical concepts that you need for immediate clinical decision making. Let us summarize what a resident should do when he gets a patient with laryngeal or hypopharyngeal cancer and asked to choose local imaging for this patient. This algorithm perfectly summarizes exactly how you should approach modality selection as an oncology resident. You must always start your baseline staging with a high quality contrast enhanced CT scan. Once you have that baseline imaging, you look at your clinical plan. You are aiming for an organ Are you aiming for an organ preservation strategy, such as a partial laryngectomy or a transoral laser resection? If you are, you must ask yourself one highly critical question before moving forward. Does this standard CT scan you did leave you with any doubt regarding early cartilage invasion or the exact soft tissue borders? If the answer is no, and the CT is completely unambiguous, you may safely proceed with your surgical planning. But if the answer is yes, you cannot simply guess now. You must actively escalate to an MRI. You must use the MRI to definitely resolve those borderline margins and meticulously assess the deep space cartilage parameters before you ever take the patient into operating room. With this, we have completed a discussion about the cross-sectional local imaging for laryngeal and hypopharyngeal cancers. This is an imaging checklist you must follow while reading imaging for these patients. This slide summarizes exactly what you must actively look for when reading any cross-sectional imaging for laryngeal or hypopharyngeal cancers. First, you must assess the spread of the tumor across the anatomical sites of the larynx. You need to clearly define if the mass is crossing from the supraglottis down to the glottis or into the subglottis. Second, look closely for any spread into deep fat compartments. This is assessed by looking for the effacement of the normal fat inside the preglottic and paraglottic space. Third, you must actively hunt for any erosive changes or transmural spread through a laryngeal cartilage. Remember that the most commonly invaded framework is the thyroid cartilage. Fourth, check if there is any extralaryngeal spread, where the tumor breaks completely out of the larynx and into the surrounding neck tissues. Fifth, systematically evaluate all the neck levels for any nodal involvement. Finally, always remember to screen for distant metastasis. You must strictly follow this exact evaluation checklist for every single scan you review in your clinical practice. This is the metastatic workup. In this step, you must accurately search for distant metastasis. Locally advanced laryngeal and hypopharyngeal cancers have a high propensity for spread to distant organs, especially lungs. You must actively hunt for this systemic spread before planning any radical local treatment. For early glottic cancers with negative nodes, a simple baseline chest X-ray is often sufficient. Truly speaking, you don't even need chest X-ray for this. But for advanced disease or clinically positive neck nodes, you must escalate to a contrast-enhanced chest CT. When will you do PET CT? Not every patient with locally advanced laryngeal and hypopharyngeal cancer require PET CT. There are really no definitive indications, but you should consider doing PET CT in those scenarios where there are very high chances of distant metastasis. So which are those scenarios? These are the 4 indications of PET CT you should remember. 1. When you have multiple cervical nodes. 2. When you have N3 node having clinical extranodal spread. 3. When you have single node which is located in the lower neck, especially in level 4. 4. When you have the post-cricoid tumor which is extending into esophagus. Otherwise, doing CT chest is often sufficient. Let us move on to discuss baseline functional assessment for patients with laryngeal and hypopharyngeal cancers. Remember, our final question is going to be whether to save larynx or sacrifice it. So the natural question is, how can we assess these functions of the larynx? How do you definitely prove that larynx is fully functional and truly worth saving? You cannot simply guess by looking at the patient from the outside. You cannot simply guess by taking history alone, physical examination alone, by doing sophisticated imaging such as a CT or MRI. You need highly objective and precise tools before you deemed a larynx functional or dysfunctional. This slide shows our complete clinical armamentarium we have to do a baseline functional assessment. There are exactly 10 essential tools you must know for a comprehensive evaluation. I have organized these 10 tools under 4 distinct headings to make it easy for you to remember. Let us quickly enumerate them. First, we have clinical evaluation tools. This includes the bedside water swallow test, like the standard Yale 3-ounce test and the modified 3 mm test. It also includes the comprehensive clinical swallowing evaluation performed by your speech and language pathologist. Next, we have instrumental imaging tools. These are your absolute diagnostic tools. Under this, we have FEES, Functional Endoscopic Evaluation of Swallowing, which uses an endoscope. Then we have VFSS, Video Fluoroscopic Swallowing Study, which uses imaging fluoroscopy. Then we have video stroboscopy and high definition rigid laryngoscopy with narrowband imaging. These two tools are optical tools which map the exact mucosal spread and vibratory function of the vocal cords. Next, we have to assess systemic physiology of the patient. A functionally preserved larynx requires a patient who can physically survive the brutal treatment. This includes objective nutritional screening like MUST or PGSGA to catch severe cancer cachexia early. It also strictly requires pulmonary function test and peak cough flow evaluation. If your patient does not have the lung reserve to physically cough out aspirated food, you cannot safely offer them organ preservation. Finally, we have patient-reported outcome measures or PROMs. Patient-reported outcome measures are actually validated clinical questionnaires. They are answered directly by the patient, not by the doctor. They tell us exactly how the swallowing and voice problems are already affecting the patient's daily quality of life. There are many questionnaires, but the most validated ones are the EAT-10, MD-ADI, EORTC, and the Voice Handicap Index. You must master all 10 of these tools to make the right clinical decision for your patient. I have discussed all of them in my previous videos in great details. I have given a link for this video in the description. You must watch it. This slide brings together exactly how we use the penetration aspiration scale to choose between organ preservation and surgery. We have already discussed these exact clinical pathways in great details during our earlier FEES discussion. Therefore, we will not go into deep details again right now. Let us just do a very quick and practical recap. Scores of 1 and 2 indicates a completely functional larynx. These patients are excellent, ideal candidates for radical chemoradiotherapy. Score of 3, 4 and 5 shows that there is penetration. Score 3 and 4 could easily be taken for radical chemoradiation. However, it is score 5 where situation is tricky. Some argue that radical chemoradiation can be attempted. Some believes that we should go for total laryngectomy. Scores of 6 and 7 represents a strict mechanical failure caused by the physical bulk of the tumor. These patients remain very high-risk candidates for chemoradiation. Hence, most will go for total laryngectomy for these scores. A score of 8 or silent aspiration represents a catastrophic neurological failure. The tumor has irreversibly destroyed the vital sensory nerves. Treating this specific larynx with radiation will only lead a rigid, permanently open pipe directly to the lungs. Therefore, non-surgical organ preservation is absolutely contraindicated. An upfront total laryngectomy is strictly necessary here to safely secure the airway and save the patient's life. Let us now move on to the main topic of our discussion, the treatment of advanced laryngeal and hypopharyngeal cancer. Managing this specific group of patients is a major challenge in clinical practice. In the upcoming slides, we will review how the treatment approaches have changed over time. We will discuss the landmark clinical trials that formed our current practice. Finally, we will evaluate the modern standard of care protocols that guide our tumor board discussions today. Let us look back at the time before the late 80s. Today, if a patient comes to you with locally advanced laryngeal cancer, you might expect to offer chemoradiation to save their larynx. But the reality of that time was very unexpected. The only goal back then was to increase overall survival at any functional cost. There was no attempt to save the organ. You couldn't even imagine that locally advanced larynx can be treated without removing it. Instead, the strict standard of care was to perform an upfront total laryngectomy followed by post-operative radiotherapy. This surgery meant removing the entire larynx. It permanently separated the breathing and digestive tracts. The patient had to breathe through the permanent hole in their neck called a tracheostoma for the rest of their life. To a modern resident, it is quite surprising that such a huge loss of function was a very routine and accepted treatment for all advanced cases. To continue our discussion on this historical approach, this slide perfectly illustrates the clinical mindset of that time. As we just noted, the treatment scale was completely tipped towards eradicating the cancer. The medical community gave almost no importance to preserving the human voice or normal physical function. The strict clinical rule was always the same: maximize overall survival at absolutely any functional cost. This meant doctors routinely subjected their patient to the massive trauma of an upfront total laryngectomy. Losing the larynx was simply accepted as the unavoidable price a patient had to pay to live. Look closely at the patient on this slide, diagnosed to have locally advanced laryngeal or hypopharyngeal cancer in those years. Imagine the heavy guilt doctors would have felt during that time. They would have told patient that they would cure his cancer, but in return, they removed the entire larynx. They left him with a permanent hole in their neck just so they could breathe. Just pause here and think about the consequences of this surgery. Think about the daily frustration and deep sadness of these patients would have gone through. They completely and irreversibly lost their natural speech. They can no longer talk to his loved ones. Their ability to swallow normally is permanently gone. Because of this physical trauma, they most likely would have lost their job. They would hide away from the world. They would have suffered from profound social isolation and probably severe depression. We saved their lives, but we destroyed the way they lived. As doctors, looking at patients suffering like this caused immense guilt. It was deeply frustrating to offer a cure that felt like a lifelong punishment. Just think about this for a moment. We had to ask ourselves, is saving a life truly a success if we take away the person's ability to communicate and connect? This deep frustration and shared guilt is what finally forced the medical world to urgently look for a better way. On one hand, the treatment was a clear oncological success. It successfully destroyed the cancer and maximized the overall survival of the patient. But on the other hand, it was a massive functional failure. The surgery left behind a trail of physical and psychological destruction. They suffered from the permanent loss of their natural speech, deep social isolation, and severe clinical depression. We were curing the disease but destroying the person. This terrifying baseline of lifelong isolation and clinical depression created the absolute necessity for modern organ-preserving treatments. We urgently needed a way to cure the disease while maintaining a functional larynx. This critical need led to a major turning point in head and neck oncology. Let us now look at the landmark research that finally changed our therapeutic benchmark. In 1981, a study was conducted by McNeil and colleagues, which led to a major shift in our clinical philosophy. They asked normal people without cancer to consider a hypothetical medical gamble. As a resident, you must know an accurate and important fact about this study. The researchers did not ask cancer patients. They actually gave some questionnaires to healthy individuals such as firefighters and business executives. They asked them to choose between living a longer life without a voice or a potentially shorter life with their natural voice. Once again, they asked them to choose between living a longer life without a voice or a potentially shorter life with their natural voice. Just think about this question they asked. The results were truly surprising. A significant proportion of these healthy individuals were willing to live a shorter lives than lose their normal voice. Once again, a large number of these healthy individuals were willing to accept a shorter life just to keep their ability to speak. They clearly preferred a shorter life if they could keep their ability to speak naturally. This single perception of normal people created the organ preservation paradigm. It forced the medical world to change its treatment goal. Instead of only measuring overall survivals, doctors started focusing on keeping the organ fully functional. To make this new goal of organ preservation a reality, doctors needed a smart strategy. They started using neoadjuvant or induction chemotherapy as a biological test. The main goal was very clear: eliminating the need for radical disfiguring surgery without lowering the overall survival of the patient. The underlying theory was that if a tumor responds well to chemotherapy, it will also respond well to radiation therapy. By giving the chemotherapy first, usually 2 or 3 cycles of drug like cisplatin and 5-fluorouracil, doctors created a live test right inside the patient. After these cycles, they would check the tumor response. If the drugs successfully worked and decreased the tumor, the patient would then receive definitive radiation to cure the disease. However, if the tumor did not respond to these drugs, the patient would not get radiation and would go straight to surgery. This clever pivot allowed doctors to safely save the organs in patients who responded well, while sending the non-responders to immediate surgery. Let us look at a truly exciting moment in the medical history. A famous trial published in 1991. It is VA Laryngeal Cancer Study Group Trial, popularly called as VA trial. This famous trial was conducted in the United States. It was a massive multi-center randomized clinical trial. These participating hospitals were all part of the national healthcare system run by the US government. Because the study tested patients across the entire country, medical world fully trusted its groundbreaking results. This trial was published in the New England Journal of Medicine journal in 1991. This trial is extremely important. It changed the way we used to treat locally advanced laryngeal and hypopharyngeal cancers. Every resident must know this. They should be able to rattle out these details even if you are woken up from a deep sleep. It is so very important. When the trial was published in 1991 in the New England Journal of Medicine, the medical community was completely surprised. The results generated immediate and massive attention within both the scientific community and the mainstream news media. So much so that it was featured prominently in major national newspapers, including the New York Times. This trial also served as a model for organ preservation for many other cancers such as bladder, breast, and anal canal. Let us go into its detail. Researchers took 342 patients with advanced stage 3 or 4 laryngeal cancer. Normally, every single one of these patients had to lose their entire voice box to a total laryngectomy. But in this trial, they divided these patients into 2 groups. The first group received the standard treatment of that time. This means immediate surgery to remove the larynx, followed by post-operative radiation. For the second group, they tried something completely revolutionary. They gave them experimental induction chemotherapy using the drugs cisplatin and 5-fluorouracil. This created a live biological test. If the tumor responded by at least 50%, they cancelled the upfront surgery. Instead, the patient received definitive radiation to cure the cancer. If the tumor did not respond well, only then did they take the patient to surgery. This trial completely changed everything physicians believed. Let us look at the truly shocking results of the VA trial. For the group of patients who had the standard upfront total laryngectomy, the estimated 2 years overall survival was 68%. What about the experimental group that received induction chemotherapy followed by radiation? Their estimated 2-year overall survival was also exactly 68%. The survival rates for both groups were completely identical. Look at this Kaplan-Meier curve for comparison between the two treatment arms for overall survival. The graph tracks the survival of both patient groups over a period of 60 months. One curve represents the patient who received the standard approach of upfront surgery. The other curve represents the patient who received the experimental treatment, radical radiotherapy in chemoresponders. As you can clearly see, these two curves overlap almost perfectly throughout the entire timeline. Look at exactly at 2-year mark. The overall survival rate was exactly 68% for both groups. The statistical analysis confirmed there was absolutely no significant difference between them. This identical survival curve is incredibly important because it proved the ethical viability of the new treatment paradigm. Let us pause here and see exactly what these identical 68% survival rates meant for the medical world and the patients. By avoiding a mutilated total laryngectomy surgery and trying an organ-preserving chemoradiation treatment in chemotherapy responders, the treatment did not lower a patient's chances of survival. Before this trial, skeptics feared that leaving the tumor in the body and not removing it by surgery would make the cancer to spread and ultimately patient will die. But the data proved otherwise. For the very first time, doctors could confidently offer their patient a chance to keep their natural larynx for voice and avoid a permanent tracheostoma without removing it. Let us now look at the true miracle of the VA trial. This slide shows the exact numbers you must burn into your memory. The most incredible finding was how beautifully these advanced tumors reacted to the induction chemotherapy. An amazing 85% of patients demonstrated a major tumor response to the induction chemotherapy. Major response here means after receiving 2 cycles of induction chemotherapy, tumor decreased in size by at least by 50% in 85% of patients. What this meant for the patient? The major response of 85% acted as the crucial biological litmus test for this trial. If a patient's tumor achieved this major response, it proved the tumor was highly sensitive to the treatment. These responding patients were then given a 3rd cycle of chemotherapy and sent for definitive radiation therapy to cure the disease instead of total laryngectomy. If a patient did not achieve this major response, they were classified as a non-responders and were taken directly to total laryngectomy. Because of this fantastic response, we saw an absolute breakthrough in patient care. A 64% of patients who underwent radiation successfully retained their functioning natural larynx. This means they could preserve their natural human voice and completely avoided a permanent tracheostoma. This was a massive victory for our patients. Finally, we must address a very important safety note for the surgical team. What about the patient who did not respond to induction chemotherapy and eventually needed a salvage total laryngectomy? The trial proved that the surgical complications for those requiring salvage procedures remained highly manageable. Attempting to safely save the larynx first did not make the salvage surgery dangerous. This is exactly why this trial changed the world and why every single one of you must know these results. You might be wondering something very important. You might be thinking, if these two treatments were so completely different, why was the survival exactly the same? How can we achieve the same survival without removing that organ? The answer lies in a fascinating shift in how the cancer recurred. The two treatments shifted the pattern of recurrence in completely opposite direction. See here. For the patients who had the standard upfront surgery, the local recurrence was incredibly low at just 2%. However, the rate of distant spread to other organs was dangerously high, 17%. Now look at the experimental induction chemotherapy followed by radiation group. This showed the exact reverse pattern. Because the organ was left inside the body, the local recurrence was higher at 12%. But the induction chemotherapy acted like a powerful systemic shield. They took care of the systemic disease and successfully dropped the distant metastasis down to just 11%. Surgery controlled the local site perfectly, but failed to address distant micrometastatic spread. Chemotherapy tackled the systemic therapy beautifully, but left the local site more prone for recurrence. These two very different paths perfectly balanced each other out. This beautiful clinical trade-off is exactly why the overall survival rates remained completely identical between the two arms. Let us move on to this next incredibly important finding of this trial when it was updated after 7 years and published in 1998. Surviving cancer is only the first our job. We must also ask ourselves how these patients in both arms were actually living after their treatment. What was the true human cost of these two different treatments? To answer this, trial published a long-term quality of life update in 1998. They evaluated the surviving patients at the 10+ year mark. They directly compared the patients who underwent radiation with those who underwent laryngectomy. To do this scientifically, the researchers introduced extremely robust metrics. They used the SF-36 General Health Survey to measure general health status. SF-36 is a commonly used and well-validated survey survey instrument designed to measure a patient's general health status. They also used the specific head and neck quality of life instrument known as HNQOL. These advanced tools allowed them to focus on deeply personal areas of a patient's life. They specifically measured physical functioning, chronic pain, and emotional well-being. As future oncologists and surgeons, you must remember these results. A patient's emotional well-being and freedom from pain matter just as much as their overall survival. In the 1991 survival results shocked the surgical world. What came next in 1998 changed everything. Let us look at the exact numbers on this shocking slide. When comparing the two treatment groups, the differences in patient suffering were absolutely staggering. First, look at the mental health aspect. Patients in the organ preservation group, that is induction chemo followed by radiation, scored significantly better on the mental health domain. They achieved a score of 76 compared to a 63 in the upfront surgery group. Now look closely at the clinical depression rates. An alarming 28% of patients who underwent the upfront laryngectomy was suffering from clinical depression. However, in the chemoradiation group, that number was nearly cut in half, dropping to only 15%. The benefits were not just in their mind. Look at the freedom from the pain aspect. The patients who underwent chemoradiation reported massively less bodily pain. They scored an impressive 88.5 in freedom from pain. In stark contrast, the laryngectomy patients scored a painful 56.5. What does these results tell us? They tell us that keeping the larynx intact by giving radiation gave these patients better quality of life. Let us bring all these incredible results together. Look at this beautiful triad of cancer care on your screen. This slide perfectly summarizes why the VA trial is a legendary milestone in oncology. First, doctors achieved an identical estimated 2-year survival rate of exactly 68%. Second, they successfully preserved a natural larynx in 64% patients. Third, they gave these survivors tremendous freedom from crushing depression and severely bodily pain. When you combine these three massive victories, you get a fundamental shift in our profession. VA trial did not just change a medical guideline. It completely changed the entire philosophy of cancer care. So this is all that I wanted to tell you about this trial. Let's move on. In this slide, I have summarized the entire VA trial. Take a screenshot of it for a quick review. Let us move to the next important practice-changing trial. While America was still doing VA trial for locally advanced laryngeal cancers, EORTC group from the Europe also raised a very similar question for locally advanced hypopharyngeal cancers. They asked, could this exact same organ preserving approach be safely tested in hypopharyngeal cancers? EORTC started this trial in 1986, specifically for hypopharyngeal cancer. This was a highly debated idea back then. Hypopharyngeal cancer is known for its aggressive biological behavior and a terrible overall prognosis. It is a very high rate of early spread to the lymph nodes on both sides of neck. Because of this aggressive behavior of hypopharyngeal cancer, the standard treatment was always a massive upfront surgery followed by post-operative radiotherapy. This surgery permanently sacrificed the patient's natural voice. To challenge this traditional standard practice, the EORTC pushed forward with this groundbreaking study in 1990 and published their preliminary results in 1996. This was the design of this trial. Between 1990 and 1993, it randomly assigned 194 eligible patients into two distinct groups. The first group received the standard approach of immediate radical surgery, followed by post-operative radiotherapy, which was the standard of care for these tumors at that time. The second group was treated with organ preservation approach. They received induction chemotherapy using a powerful combination of cisplatin and 5-fluorouracil. This chemotherapy acted as a crucial biological test. If a patient achieved a complete response to the drugs, they were treated with radical radiation with 70 Gray and saved their larynx. However, if the tumor did not achieve a complete response, the preservation attempt was stopped. These non-responding patients were immediately taken for total laryngectomy surgery followed by post-operative radiation. So the trial design in this trial was quite similar to VA trial, except that only complete responders were taken up for radiation, unlike complete and partial responders in VA trial. This trial was specifically designed as a non-inferiority trial to prove that the experimental arm was not worse than the standard upfront surgery arm. The researchers set a strict non-inferiority threshold at a hazard ratio of 1.43. Let us look at the stunning preliminary results of this trial on a screen. The first major victory was the amazing tumor response. 54% of patients achieved a complete response at the primary site after induction chemotherapy. But the trial revealed another massive systemic benefit. The chemotherapy arm had significantly fewer distant metastases compared to surgery arm. The rate of distant spread dropped from 36% down to 25% with a p-value of 0.041. Now look at the 1996 preliminary conclusion box at the bottom of the slide. The median survival was actually longer in chemotherapy arm. It was 44 months for the chemotherapy group versus 25 months for the surgical group. The hazard ratio was 0.86. This exact number successfully cleared the predefined 1.43 non-inferiority threshold. What did this all mean for the medical world? It proved definitely that larynx preservation in hypopharyngeal cancer was entirely feasible. Doctors could finally save the organ without jeopardizing the patient's early survival. This slide shows the final 10-year results of the EORTC trial. There are some important statistical concepts here. You need to understand these results carefully. The median follow-up time was an incredible 10.5 years. The hazard ratio was 0.88, which mathematically favored the chemotherapy arm. The analysis achieved a highly significant p-value of 0.002. You might look at this and falsely assume the chemotherapy was superior to surgery. However, this p-value provides definitive proof of non-inferiority, not superiority. This trial was exclusively designed to prove the experimental arm was not significantly worse than standard upfront surgery. Researchers set a strict non-inferiority threshold at 1.43. The p-value simply proves the hazard ratio was safely below this strict red line. Because the actual hazard ratio's confidence interval crossed 1.0, ranging from 0.652 to 1.19, there is no statistically significant difference in the overall survival. Look at how the 10-year overall survival curves overlap perfectly. Both treatment resulted in an identical survival rate of approximately 13%. This is the true clinical victory. Because you can safely preserve the larynx with organ preservation treatment without affecting long-term survival. This is a long-term head-to-head comparison between surgical arm and non-surgical arm. 10-year overall survival rate was 13.8% for immediate surgery and 13.8% for the experimental induction chemotherapy arm. There was no difference. The 10-year progression-free survival rate was 8.5% for the immediate surgery arm and 10.8% for the experimental induction chemotherapy arm. There was no difference. What is the ultimate clinical conclusion we must draw from these numbers? The long-term survival for advanced hypopharyngeal cancer remains intrinsically poor across the board. However, the overall disease control is statistically equivalent regardless of the primary treatment modality. This clearly establishes that you can safely preserve the patient's larynx without ever compromising their long-term chance of a cure. Let us see survival with a functional larynx in organ preservation arm. The researchers defined true organ preservation with very strict clinical rules. True preservation strictly meant the patient survived without any local disease returning, without needing a tracheostomy, and without needing a feeding tube. When evaluating the entire intention to treat chemotherapy arm, the overall 10-year survival with the functional larynx was 8.7%. However, you must look at the real-world impact for the patients who actually survived a whole decade. Of the patients in the experimental arm who were still alive at the 10-year, an incredible 50% successfully retained their natural functional voice box. This proves that over half of these long-term survivors kept their natural voice. This beautiful functional outcome is defining victory of this trial. Let us examine what happens when the primary treatment fails. Look at the immediate surgery arm in the red box. There were 12 local failures in this standard treatment group. Unfortunately, the salvage interventions for these surgical patients were highly limited and mostly unsuccessful. In fact, 11 out of those 12 local failures remained ultimately uncontrolled. Now look at the experimental chemotherapy arm in the blue box. This group experienced 20 local failures. However, 10 of these patients successfully underwent salvage surgery. The incredible result is that 6 out of those 10 patients were successfully controlled. What is the key clinical takeaway? Salvage surgery remains a highly viable and effective safety net. You can safely attempt to preserve the organ because surgery is always there for patients who fail the induction chemotherapy and radiotherapy pathway. Let us summarize these two practice-changing trials we just discussed. In the 1990s, these two landmark trials established the non-surgical alternative for our patients. These trials proved that induction chemotherapy followed by radiation could successfully save the larynx without increasing mortality. Let us look at the VA Laryngeal Trial on the left side. In 1991 trial, this trial evaluated patients with laryngeal cancer. It proved that 2-year survival was identical at 68% for both treatment groups. Also, 64% of the patients in the experimental arm successfully preserved their larynx. This trial also showed that distant metastases were effectively reduced. Now look at the EORTC T24891 trial on the right side. This trial focused on patients with hypopharyngeal cancers. The 10-year overall survival remained identical at approximately 13%. Most impressively, over 50% of the long-term survivors successfully retained their natural voice box. What is the conclusion of these two trials? Chemo selection absolutely works. Radiation in chemo responders work very well. We can safely reserve laryngectomy for salvage treatment without compromising our patient's survival. This slide shows practice-changing paradigm. First, we have the VA trial for America. This trial definitely proved the feasibility of organ preservation and established equal survival rates. Next, we have the EORTC trial from Europe. This trial successfully confirmed this preservation approach across a broader European population. Today, in modern era, we are moving towards an exciting futures using biomarkers, targeted therapy, and chemo prevention. What is the ultimate clinical takeaway from these milestones? Total laryngectomy was permanently moved from the first-line standard to a salvage therapy. Organ preservation became the absolute gold standard. Organ preservation strategies fundamentally preserve the human identity without ever sacrificing the cure. Let us conclude the ultimate modern philosophy of laryngeal preservation. In our brutal war against cancer, we do not always have to destroy the patient just to save them. With the right drug, the right radiation, and a daring leap of faith, we can successfully save their life. Most importantly, we can let them keep their natural voice to tell their own story. This perfectly functional, human-centered survival is the true victory of our medical profession. Let us dive deep into this next famous study on your screen. This is the RTOG 9111 trial. The previous trial successfully proved we could save the larynx with chemotherapy and larynx. However, we needed to find the absolute best way to deliver these treatments. This slide perfectly introduces our deep dive into the RTOG 9111 trial data and its famous 10-year controversy. This trial evaluated the ongoing paradigm shift in locally advanced laryngeal cancer. It highlights a very serious clinical tension that every oncologist must face. We must carefully balance three vital factors: organ preservation, treatment toxicity, and the patient's overall survival. Let us look at the exact design of this massive trial on the next slide. Let us examine the refinement of our laryngeal preservation strategy for this trial. Total laryngectomy was the historical surgical standard for locally advanced disease before 1990s. Then the VA trial created a major breakthrough. This trial used induction chemotherapy with cisplatin and 5-fluorouracil followed by radiation. This approach successfully preserved the larynx in 64% of patients. More importantly, the survival was completely equivalent to total laryngectomy at 68% at 2 years. However, there was still a very important unanswered question at that time. What is the optimal timing and contribution of chemotherapy to maximize preservation? To answer this exact question, researchers designed the famous RTOG 9111 trial. Let us look at the exact design of this massive trial. The RTOG 9111 trial evaluated 547 patients. These patients had stage 3 or stage 4 squamous cell carcinoma of the glottis or supraglottis. Importantly, their disease was considered entirely curable with surgery. The primary endpoint of this study was laryngeal preservation. Researchers randomly assigned these patients into 3 distinct treatment groups. First group was the induction arm. They received 2 to 3 cycles of cisplatin and 5-fluorouracil. This was followed by definitive radiation of 70 Gray. The second group was the concurrent arm. They received cisplatin specifically on days 1, 22 and 43. The third group was the control arm. These patients received 70 Gray of radiation alone. This design finally allowed us to test the absolute best timing of chemotherapy. Let us look at the highly anticipated winner of the RTOG 9111 trial on your screen. The initial 2003 result revealed a massive victory for the concurrent chemotherapy arm. This experimental group achieved an incredible 88% laryngeal preservation rate. This was significantly superior to the 75% preservation rate for the induction chemotherapy arm. It also completely beat the 70% rate for the radiation alone group. Now let us look at the loco-regional control rates. The concurrent arm achieved a significantly better disease control rate of 78%. It was 61% for the induction arm and the dismal 56% for the radiation alone arm. However, the trial also revealed a very important benefit. Both of the chemotherapy arms successfully suppressed distant metastasis when compared to using radiation alone. What was the immediate result of this powerful data? Because of these dominant numbers, concurrent chemoradiation was declared to be an absolute winner. Let us compare acute toxicity between these 3 treatment arms. The concurrent arm was a massive double-edged sword. Look at the severe high-grade acute toxic effects across all 3 arms. The overall rate of severe acute toxicity was 81% for the induction chemo group, a nearly identical overall severe acute toxicity grade of 82% for the concurrent group. The radiotherapy alone group had a much lower severe acute toxicity rate of 61%. Compare severe mucosal toxicity. The concurrent arm suffered a massive 43% rate of severe mucosal stomatitis. This was nearly 2 times as frequent as the 24% mucosal toxicity rate seen in both the induction arm and the radiotherapy alone arm. This intense acute mucosal damage is the severe immediate cost of the concurrent approach. Let us look at the unsettled dust of this landmark trial on your screen. When the RTOG 9111 trial was initially published in 2003, it had a median follow-up of exactly 3.8 years. At that time, the data demonstrated a massive victory in laryngeal preservation. Because of this powerful early data, concurrent chemoradiation rapidly became the absolute standard of care for locally advanced disease. However, we need to deeply examine the 10.8-year update of this exact same trial. This long-term data forces us to ask a terrifying clinical question. What is the true value of saving an organ if the treatment ultimately compromises the patient's lifespan? Let us look at the actual 10 years numbers on the next slide to understand this massive survival controversy. Let us look at who was undisputed champion of local control on your screen. Look at the 10-year laryngeal preservation rates on the left side of the slide. It was highest in concurrent arm, 81.7%, followed by 67.5% in the induction arm and 63.8% in the radiation alone arm. Look at 10-year local regional control rates on the right side. The concurrent CRT arm dominated again with a 65.3% control rate. This was significantly superior to the 48.9% rate for the induction PF arm and 47.2% rate for the RT alone arm. What is the ultimate clinical takeaway? Concurrent CRT is significantly superior at preventing local tumor regrowth and avoiding salvage laryngectomies. Let us look at the ultimate composite endpoint of this trial. 10-year laryngectomy-free survival. Laryngectomy-free survival strictly tracks if a patient is alive and has an intact larynx. Look at the two overlapping circles in the center. The induction arm achieved a 28.9% laryngectomy-free survival rate at 10 years. The concurrent arm achieved a 23.5% laryngectomy-free survival. The hazard ratio comparing these two groups is 1.05 with a p-value of 0.68. This shows that the laryngectomy-free survival reached an absolute statistical tie between the two chemotherapy approaches. Now look at the RT alone arm. This group had a much lower 17.2% laryngectomy-free survival. So what is the final conclusion? The chemotherapy arms remained significantly superior to RT alone, but they were completely equivalent to each other. Now let us examine a terrifying survival paradox on this next slide. Listen carefully. As you can see, This graph tracks the overall survival over 10 years. Look closely around the 4-year mark on the timeline here. After this point, the survival curves begin to separate and undergo slight crossover. See orange color curve for the concurrent arm. It is coming down gradually below curves of induction as well as radiation alone. The induction chemotherapy arm achieved a 38.8% overall survival rate at 10 years. The radiotherapy alone arm achieved a 31.5% survival rate. Shockingly, the concurrent chemoradiotherapy arm dropped to the lowest overall survival rate of 27.5%. This creates a stunning 11% absolute survival advantage for the induction arm over the concurrent arm. See the widening gap between induction and concurrent arms as we move to the right. But this difference is statistically not significant. But the trend seems to be favoring induction arm. So we can say, despite completely dominating local disease control, the concurrent arm demonstrated statistically non-significant worse overall survival. Let us look at this comprehensive 10-year efficacy summary. This table summarizes all the long-term endpoints for the RTOG 9-1-11 trial. Let us review the primary endpoint of laryngectomy-free survival in the first data column. The induction arm achieved a 29% rate and the concurrent arm achieved a 24% rate. Both of these results were significantly better than the dismal 17% rate seen with RT alone. Next, look at the larynx preservation and locoregional control columns. The concurrent arm absolutely dominated with a 82% preservation rate and a 65% locoregional control rate. These concurrent results were significantly superior to both the induction arm and the RT alone arm. Finally, you must look at the overall survival column on the far right. The induction arm achieved the highest overall survival at 39%. Shockingly, the concurrent arm dropped to the lowest overall survival at 28%. This entire table captures a confusion between achieving local tumor control and overall survival. Now a natural question arises here. How could the absolute best treatment, that is the concurrent chemoradiation, for the local tumor control seems to be turning out the worst treatment for the overall survival? How could concurrent chemoradiation completely dominate local tumor control, yet results in the worst 10-year overall survival rate? Just think about that. Let us find out the reason on the next slide. Let us look at the shocking truth on your screen. This slide perfectly explains why the concurrent arm suffered the worst overall survival. Look at the rate of deaths entirely unrelated to cancer or the treatment itself. The radiotherapy alone group had a 16.9% rate of these unrelated deaths. The induction chemotherapy group had 20.8% rate. Shockingly, the concurrent chemoradiation group experienced a massive 30.8% rate of death entirely unrelated to cancer or treatment. The question is, Why did the group with the best cancer control, have the worst overall survival? We will uncover the hidden reality behind these massive non-cancer deaths on the next slide. Let us uncover the hidden truth on this screen. Look at the left side of the slide. On paper, the 10-year severe late toxicity rates looked very similar. The concurrent arm reported a 33.3% rate of severe grade 3 to 5 late toxicity. The induction arm reported a 30.6% rate. Even the patient-reported swallowing problems seemed only slightly worse. They ranged from 17 to 24% for the concurrent group versus 13 to 14% for the induction group. But this official data hid a massive problem. Look at the reality flowchart on the right side. The trial investigators suspected a hidden deadly chain of events. The intense concurrent treatment caused severe mucosal and pharyngeal damage. This damage led to silent aspiration. Silent aspiration ultimately caused repeated fatal pneumonias. Our standard toxicity grading system totally missed these deadly events. Because of this, these treatment-related deaths were wrongly counted as completely unrelated to the cancer. Look at the ultimate clinical verdict on your screen. This scale perfectly captures the massive tension between our surrogate endpoints and the patient's actual lifespan. We cannot claim success if our patients are succumbing to severe treatment toxicity with an intact larynx. Overall survival absolutely matters. Now look at the powerful conclusion at the bottom of the slide. The induction chemotherapy approach mathematically outperformed the radiation therapy alone arm across all 14 clinical endpoints. Furthermore, induction chemotherapy showed a massive 11% holistic survival advantage over the concurrent arm. This data proves that we must always weigh the value of the preserved organ against the true cost of the patient's life. Let us apply these sobering lessons to our modern clinical practice. Look at the warning sign on the left side of slide. We must always remember that concurrent chemoradiotherapy is a severe double-edged sword. You must never conflate laryngectomy-free survival with overall survival. Now look at the right side to see how we are upgrading our clinical tools. First, we are replacing older 2D planning with highly conformal IMRT. Second, we are replacing the older PF regime with taxane-based induction, especially the TPF regime. Look at today's ultimate mandate at the bottom of the slide. We must maximize the massive local control benefits of the RTOG 9111 trial while aggressively mitigating the devastating quiet late toxicities. Let us look at the next massive clinical evolution on your screen. This slide shows the critical transition from the PF to TPF induction in head and neck cancers. This data comes directly from the landmark TAX 324 trial. We started with the legacy baseline PF backbone consisting of platinum and 5-fluorouracil. Then we added a taxane specifically docetaxel, to create the formidable TPF regime. Look at the right side to see the incredible long-term results. The legacy PF cohort achieved a 42% survival rate. However, the new TPF cohort achieved a much higher 52% survival rate. This created a massive 10% overall benefit at 5 years. Let us look at this another very important trial. GOTEC 20000A1 trial. This was a phase 3 randomized trial. It included exactly 213 operable patients who initially required a total laryngectomy. The researchers compared exactly 3 cycles of traditional PF against exactly 3 cycles of the new TPF regime. Look at the overall response rate to induction on the bottom left. The legacy PF arm only achieved a 59.2% response rate. However, the TPF arm achieved a massive 80.0% overall response rate. Now look at the incredible 3-year actuarial larynx preservation rates. The PF arm only preserved the larynx in 57.5% of patients. But the powerful TPF regime achieved a spectacular 70.3% laryngeal preservation rate at exactly 3 years. This data proved that adding a taxane created a vastly superior weapon for saving the natural voice box. Look at the toxicity profiles and trade-off between PF and TPF. This slide highlights the different side effects seen in the GOTEC 2001 trial. Look at the legacy PF regime. This older treatment was completely dominated by mucosal and platelets toxicities. Patients in the PF group suffered from more grade 3 and 4 stomatitis. They also experienced more severe grade 3 and 4 thrombocytopenia. Now look at the powerful TPF regime. Adding docetaxel totally shifted the toxicity profile towards severe hematological risk. Patients in the TPF group suffered from increased grade 4 neutropenia. They also experienced significant more dangerous febrile neutropenia. To achieve the massive efficacy of TPF, you must aggressively manage this new hematological toxicity profile. Adding docetaxel completely transformed the old PF backbone. This new TPF regime does bring distinct neutropenic challenges. However, you must look at the incredible clinical rewards. The TPF regime achieved a massive 80% overall response rate. It also delivered superior survival and much higher larynx preservation. Today we can confidently say that TPF stands as the absolute undisputed standard of care for induction chemotherapy. As per guidelines, as of today, we have 2 different treatment options for locally advanced laryngeal and hypopharyngeal cancers as laryngeal preservation strategies. Radical concurrent chemoradiation and induction chemo followed by radiation. As per NCCN guideline, both are equally as category 2A. Which one will you choose then? Let us look at the primary indications for induction chemotherapy. When should we use the powerful TPF regime in our modern clinics? There are no clear evidence-based indications, but most of us believe that whenever you suspect that the patient has very high chances of distant metastasis, induction chemotherapy works well. Look at the first major indication for high nodal burden. Patients with clinical N2 or N3 disease face a massive risk of distant micrometastasis. We use induction TPF to aggressively attack this systemic threat early in the treatment. This early systemic attack also perfectly downstages the bulky regional disease. Now look at the second major indication for bulky T3 disease. We use induction chemotherapy to rapidly shrink the massive tumor volume. This rapid shrinkage helps our patient completely avoid a permanent tracheostomy before they even start their radiation. So induction chemotherapy with TPF is our absolute best weapon for high nodal burden and bulky local tumors. Let us look at the modern standard of care on your screen. This slide outlines the two primary non-surgical pathways for appropriately selected patients with T3 and low volume T4A disease. In fact, as per NCCN guidelines, both are equal as category 2A. Look at path A on the left. Concurrent chemoradiotherapy remains our absolute preferred standard of care. This approach uses high dose cisplatin at exactly 100 mg per meter square every 3 weeks alongside radiation. We prefer this path because it delivers the absolute highest rates of locoregional control and larynx preservation. Now look at path B on the right side of the slide. Induction chemotherapy with formidable TPF regime is considered an alternative approach. We specifically reserve this powerful induction path for patients who require rapid symptom relief. We also use it for patients with bulky nodal disease who face a massive risk of distant metastasis. Let us look at the ultimate 30-year evidence. This one slide perfectly summarizes the 4 most important trials in laryngeal oncology. First, look at the VA Laryngeal Trial from 1991. This proved we could use induction PF and radiation to save the larynx in 64% of patients. It achieved this while keeping the 2-year overall survival completely equal to surgery at 68%. Next, look at the EORTC 24891 trial. This trial proved the exact same preservation concept for hypopharyngeal cancers. It showed an identical overall survival at 10 years of roughly 13% for both treatment arms. Then look at the landmarks RTOG 9111 trial from 2003. This massive trial made concurrent chemoradiation the absolute standard of care. It achieved this by delivering an incredible 84% laryngeal preservation rate at 5 years. Finally, look at the GOTEX 2001 trial from 2009 at the bottom. This trial proved that if you must use induction therapy, the TPF regimen is the absolute standard. It delivered a massive 80% response rate and a much higher 75% larynx preservation rate compared to the older PF regime. This simple matrix perfectly maps the entire 30-year evolution of our modern organ preservation paradigm. Administering high-dose cisplatin concurrently with radiation is exceptionally difficult for patients to tolerate after exactly 3 cycles of heavy TPF induction. What can we do to make it more tolerable? Cetuximab was found to be one option considering its safety profile shown in Bonnet's trial. Let us dive into an important trial, Trampoline trial. Why was this trial conducted? Because cetuximab previously showed improved survival without increasing severe mucosal toxicity in Bonnet's trial, researchers hoped it could serve as a less toxic alternative. Therefore, this trial explored the absolute safest way to treat patients sequentially. Look at the initial patient cohort on the far left. The investigators started with exactly 153 patients with stage 3 or 4 larynx and hypopharyngeal squamous cell carcinoma. All patients received exactly 3 cycles of the powerful TPF induction regime. Now look at the critical pivot point in the middle of the flowchart. If a patient achieved less than 50% tumor regression, they were sent immediately to salvage surgery. Poor responders went for surgery. 116 excellent responders who achieved at least 50% regression and restored vocal cord mobility moved forward. These responders were randomized into exactly 2 distinct consolidation arms. 60 patients received standard chemoradiotherapy utilizing 70 gray of radiation plus concurrent high-dose cisplatin at exactly 100 mg per meter square on days 1, 22 and 43. 56 patients received the bioradiotherapy utilizing 70 gray of radiation plus a concurrent cetuximab loading dose of exactly 400 mg per meter square and exactly 250 mg per meter square weekly. The primary endpoint was to evaluate the larynx preservation rate exactly 3 months post-radiation. We will uncover which arm claimed victory on the next slide. These are the clinical outcomes and toxicity profile of the trampoline trial. Look at the top 3 rows comparing the efficacy of the 2 treatment. At exactly 3 months, the larynx preservation rate was 95% for the cisplatin arm and 93% for the cetuximab arm. At exactly 18 months, the larynx function preservation was 87% for cisplatin and 82% for cetuximab. The overall survival at exactly 18 months was 92% for cisplatin and 89% for cetuximab. Statistically, there was absolutely no significant difference between these 2 treatments for any of these endpoints. Now look at the bottom 2 rows comparing treatment compliance and toxicity. Because of the severe compounding toxicities from the prior TPF induction, only 43% of patients in the cisplatin arm could receive the full protocol. However, a much higher 71% of patients in the cetuximab arm successfully received the full protocol. The cisplatin arm suffered primarily from renal toxicity, affecting 15.5% of the patients. The cetuximab arm suffered from a massive 52% rate of severe grade 3 and 4 in-field skin toxicity. Overall, both consolidation treatment caused substantial toxicity after the heavy TPF induction, but patient compliance was notably higher in the cetuximab arm. So what is the final clinical takeaways from the trampoline trial? Look at the salvage surgery paradox on the left side of the slide. At exactly 18 months, the cisplatin arm had fewer initial local failures at exactly 8.3%. The cetuximab arm had a higher initial local failure rate of exactly 14.3%. However, salvage surgery was completely unfeasible for the cisplatin patients because of severe tissue damage and toxicity. In the cetuximab arm, salvage surgery was highly feasible and completely successful in exactly 6 patients. Because of this successful salvage, the ultimate local failure rates perfectly equalized over time to 13.3% versus 10.7%. Now look at the clinical bottom line. Neither the cisplatin nor the cetuximab arm proved superior after induction chemotherapy. Also, there is absolutely no evidence that either protocol improves outcome beyond the historical standard of induction followed by radiation alone from the GOTEX 2001 trial. So the final verdict is this: the absolute optimal protocol following TPF induction is still completely undetermined. Today, radiotherapy alone remains a highly viable reference treatment after induction. Let us look at the ultimate cost-benefit analysis of the three currently available laryngeal preservation strategies. Look at the first column on the left for concurrent CRT. This approach is absolutely best for strict organ preservation and local regional control. However, there is a warning sign. It carries the highest risk of fatal late non-cancer events. Because of this severe toxicity, it ultimately delivers the lowest long-term survival at exactly 10 years as shown in RTOG 9111 trial. Now look at the second column in the middle for induction PF. This legacy approach delivered the absolute best 10-year overall survival as shown in RTOG 9111 trial. It also caused lower non-cancer mortality than concurrent chemoradiation. But it comes with a major clinical trade-off. Patients face a significantly higher rate of eventual salvage laryngectomy. Finally, look at the third column on the right for radiotherapy alone. This conservative approach boasts the lowest systemic treatment toxicity. But look at the red warning sign. It results in the absolute highest rate of local cancer recurrence. You must heavily weigh these three distinct clinical profiles before choosing a non-surgical pathway for your patients. The near future of laryngeal oncology seems very exciting. Many interesting and exciting trials are going on to see if we can incorporate immunotherapy in the induction regime. This table shows some ongoing studies. This table highlights the new wave of clinical trials testing immune checkpoint inhibitors. Researchers are actively adding powerful drugs like nivolumab, pembrolizumab, and toripalimab to our traditional chemotherapy backbones. Another interesting thing you notice in these ongoing trials is that these modern trials are moving away from simple survival endpoints. Instead, they specifically measure laryngoesophageal dysfunction-free survival, LDFS. We hope that waking up the patient's immune system will help us save the natural voice box with much less systemic toxicity. Let us look at the massive dual mandate of laryngeal oncology on your screen. Historically, treating advanced laryngeal cancer meant sacrificing the organ with total laryngectomy just to save the patient. The modern paradigms shift this to exactly two critical goals. We must aggressively cure the disease while perfectly maintaining natural function. Look at the left side of the scale for exactly three oncologic efficacy metrics. We must evaluate overall survival, local regional control, and distant metastasis prevention. Now look at the right side of the scale for exactly three quality of life metrics. We must protect natural speech, safe swallowing, and airway patency to avoid permanent tracheostomy. So what is the conclusion? No organ preservation strategy offers a survival advantage over a total laryngectomy. Therefore, preservation is only successful if the overall survival of your patient is not compromised. Let us look at the massive evolution of our clinical endpoints in laryngeal oncology. From the 1990s to the early 2000s, our old paradigm relied heavily entirely on simple anatomical preservation. In year 2009, there was a critical turning point led by an international consensus panel. We now follow a completely new paradigm with a strict functional focus utilizing the laryngo-esophageal dysfunction-free survival, LDFS. The goal is no longer just keeping the larynx physically inside the neck. Today, the ultimate goal is keeping the natural larynx working. Remember, anatomical preservation is not same as functional preservation. Our aim should be functional preservation. Let us look at the old paradigm of anatomical preservation on your screen. These were the old metrics of success from landmark VA Laryngeal Trial in 1991 and the RTOG 9111 trial in 2003. Historically, the ultimate clinical endpoint was simply to avoid a total laryngectomy. But there is a horrific clinical reality of this old metric. Many preserved organs were completely fibrotic and non-functioning. These suffering patients were left permanently tracheostomized and entirely PEG dependent. Older metrics artificially inflated organ preservation success rate by completely ignoring the quality of life of the patients. This is going to be the new functional paradigm in laryngeal oncology. We now measure our clinical success using a strict metric called LDFS, laryngo-esophageal dysfunction-free survival. Laryngo-esophageal dysfunction-free survival. This modern metric was established in exactly 2009 by an expert international consensus panel led by Lefebvre and colleagues. Future trials must strictly measure true and functional preservation instead of just simple anatomical retention. This metric forces us to make a brutal, realistic and highly patient-centric assessment of treatment morbidity. We can absolutely no longer claim clinical success if the preserved organ does not actually work. Let us break down the exact definition of laryngo-esophageal dysfunction-free survival, LDFS. There are exactly 4 failure triggers for this modern endpoint. An LDFS event is immediately triggered if any of these 4 outcomes occur. The first failure event is patient's death from absolutely any cause. The second failure event is undergoing a total laryngectomy. The third failure event is any disease recurrence. Finally, the fourth failure event is the loss of functional utility. If the preserved organ loses its natural function, the treatment is now classified as a complete clinical failure. Let us look at the true definition of organ preservation in laryngeal oncology. Anatomy is absolutely not the same as function. Look at the strict preservation formula in this slide. True functional preservation requires exactly 3 critical elements. First, the larynx must remain anatomically in place. Second, the patient must completely avoid a permanent tracheostomy at greater than 2 years. Third, the patient must completely avoid a permanent feeding tube at greater than 2 years. Leaving the larynx physically inside the neck is never the ultimate goal now. A fibrotic, aspirated or obstructed airway represents a complete clinical failure. Patients undergoing a salvage laryngectomy for a severely dysfunctional larynx may actually experience an improved quality of life compared to strict organ retention. Because of this brutal reality, modern trials evaluate our success exclusively through LDFS. Building on our previous slide, if the laryngeal anatomy is already functionally destroyed, we must never attempt to save it. Let us look at the strict indications for upfront total laryngectomy. According to both ASCO and International Consensus Guidelines, exactly 4 specific patient subsets must go straight to radical surgery. First, we must perform upfront surgery for massive cartilage dissection or through and through invasion. Second, we must operate immediately if the patient presents with a pre-treatment non-functional larynx that already requires a tracheostomy or a feeding tube. Third, we must choose upfront surgery for extensive base of tongue involvement greater than 1 centimeter. And fourth, we must strictly avoid preservation protocols if the patient has a severe medical inability to tolerate platinum-based chemotherapy due to poor performance status or severe comorbidities. For these exactly 4 scenarios, an upfront total laryngectomy is the absolute optimal choice to maximize both survival and quality of life. Let us look at the ultimate safety net of laryngeal preservation. Non-surgical strategies are only safe if we catch local failures early enough to successfully perform salvage surgery. This requires intensive surveillance. You must perform rigorous clinical examination at least 4 times in a year. You must then perform these examinations at least 3 times in year 2. You must also obtain proper post-treatment baseline imaging. You can utilize PET-CT and MRI with DWI or a contrast CT to differentiate expected treatment changes from a recurrence. Also, you must strictly incorporate routine swallowing and nutritional assessment into your follow-up clinic. There is a brutal salvage reality. If the disease completely persists or recurs, salvage total laryngectomy is absolutely required. However, you must explicitly warn your patient about the massive surgical risk. Surgical morbidity is significantly higher in these specific salvage cases. Patients face a much higher risk of severe wound breakdown and devastating pharyngocutaneous fistulas. This severe morbidity happens because of heavy tissue fibrosis and extremely poor healing in the previously radiated field. We must maintain intense clinical surveillance to quickly catch failures and save the lives for our patients. Let us wrap up this comprehensive review with a practical approach on how to manage patients with locally advanced laryngeal and hypopharyngeal cancers. First, every single patient must start with a strict multidisciplinary evaluation and baseline functional assessment. There are various tools available such as VFSS and FEES. Does the patient has any of these exactly 3 clinical features? Do they have T4 cartilage destruction, a non-functional larynx, or base of tongue involvement? If yes, follow the arrow to the left. These patients must proceed directly to an upfront total laryngectomy with neck dissection. However, if the patient does not have these features, follow the arrow to the right for the organ preservation pathway. Now there are two options. Are they at a high risk of distant metastasis with bulky nodal disease? If no, they follow the standard path to radical concurrent chemoradiation. If yes, they receive induction TPF chemotherapy first. Responders then proceed to radiotherapy, while non-responders go straight to surgery. Finally, both pathways merge at the bottom for PET-CT scan at 12 weeks to safely evaluate the neck. As you can clearly see, non-surgical organ preservation is highly complex. However, you must always remember that for a specific high-risk subset of patients, surgery is absolute only way to cure the disease and save their life. Because primary surgery remains the absolute cornerstone for these advanced cases, we must master the surgical aspect of these cancers. Therefore, my next video is going to be on the surgical management of locally advanced laryngeal and hypopharyngeal cancers. Thank you for your excellent attention today. I will see you in the next video. Signing off, Parveen Ahlawat.